The Brain Awareness Week aims to increase awareness on the progress and the benefits of brain research. That's why it's very important to have events like the one we're hosting today in the Houses of Parliament about migraine being the biggest disabler of the brain. Migraine is a very common and prevalent disorder that causes disability in all patients across different ages, and it's very important that we increase awareness about the disability of migraine and the need for further research in the migraine field. This is an exciting time actually to work in migraine research because we have newer treatments and we understand better the biology of migraine. However, we cannot talk about a cure for migraine before we understand the cause of migraine in the brain. And to understand that cause, we have to invest in further research in this field.
It's a pleasure for us to host the Migraine Awareness Day today as part of the Brain Awareness Week. As the Headache Center, we are and we have been committed to increase awareness and quality of care for migraine patients, and also increase the awareness in the public and the government on how migraines are affecting people that live with them, and how it's important to stimulate new people that have interest in migraine and get new research and new funding to expand the knowledge about this condition. We at the Headache Center here have a large multidisciplinary dedicated headache center. We look after a lot of people with migraine. We have the privilege of being able to use the state-of-the-art treatments, including some injectable treatments, the monoclonal antibodies, and neuromodulation. So we would like actually to be able to spread this message and make sure that patients get the right knowledge in terms of what treatments are available for them, and so that they are empowered and they know what is available for them and how they can treat their conditions.
Migraine is a very frequent disorder. All over the world, 18% of women and 8% of men suffer from migraine. Migraine is much more than headache. Migraine attack starts well before migraine headache. It is accompanied with a nausea, vomiting, increased in appetite. It's accompanied sometimes with odor. It finishes, then fatigues, then lasts with more than 24 hours. Migraine is also accompanied by psychiatric comorbidities like depression and anxiety. Migraine so leads to the significant burden of individuals in their social environment. So migraine is really a public health problem because so many people suffer from it. Migraine can be effectively treated. We have effective treatment medications for acute treatment, and using a preventative medication, we can reduce the frequency of a migraine by half in every second patient. Unfortunately, up to date now, migraine is widely underdiagnosed and undertreated. And I, as the president of the European Headache Federation, clearly state that it's up to us, to doctors, to patients' organizations, to pharmaceutical industry, to policymakers, to enable that people with migraine receive adequate treatment.
Good evening, ladies and gentlemen. Welcome to the Palace of Westminster. My name is Jim Fitzpatrick. I am Member of Parliament for Poplar and Limehouse, which is a constituency in Tower Hamlets in Docklands in East London. When I'm speaking to people that I haven't met before, I have to explain that I'm an East London MP because my classic Cockney accent sometimes confuses people, and they think I'm one of that northern mob who come down on a Monday morning and go back on a Thursday, but I'm here all the time. Welcome to the Churchill Room. This is one of the most interesting rooms in the palace, named and themed after the great man. His bust is usually in a little alcove here in the corner. He's portrayed there when he's father of the house. The painting behind is of the archway entrance into the House of Commons chamber, destroyed by German bombs on the 10th of May 41, rebuilt, and the archway eventually christened Churchill's Arch, to remind parliamentarians of the civilian casualties in any conflict. 60,000 civilians killed by German bombs in the Second World War, 600,000 Germans killed by British and American bombs in the same conflict. So civilian casualties anywhere. The great man lying in state in that portrait, and the portraits at the end damaged to the House of Commons, and the one in the corner painted by Churchill. So you get a chance to look round afterwards then. This is our splendid room. I was chair of the all-party parliamentary group on headache disorders. Needs to be reconstituted, primarily because I had microvascular decompression surgery for my trigeminal neuralgia at the National Hospital in Queen's Square. So having been a headache victim and or a head pain victim, I was recruited by Wendy and Migraine UK to chair the all-party parliamentary group, which I was very happy to do. We did good work for a few years, and we need to get back to that. You've got a full programme of speakers this evening. I'm sure you've seen that. The event tonight is hosted and organised by the Headache Centre, based at Guy's and Tommy's in King's College. It's endorsed by Dana and the European Headache Federation. We have 4 speakers who will speak, and then we'll have a break to allow people to replenish glasses, comfort break, whatever. And then there will be a second session with another 4 speakers. They have all been asked to be brief and to keep to time, because obviously everybody's standing and that can put pressure on everybody. So I hope you're going to have a very interesting evening. I hope you'll be able to network and enjoy the occasion and the room as well. There are plenty of refreshments. There will be plenty of time after the speakers finished. As I said, I'm going to have to be ducking and diving upstairs. Anna and Giorgio will be emceeing and introducing the speakers. But my privilege to welcome the first speaker, who's Professor Zazar Katsarava, who's Chief in Neurology at the Evangelical Hospital and Professor at the University of Essen in Germany. But he is President of the European Headache Federation and Chairman of the Global Campaign Against Headaches. He's the best person to discuss the global burden of migraine. But my apologies for leaving you, and I invite Professor Zaza to come and to speak. So, please welcome Professor Zaza Zafarava. Welcome to you.
I'm very pleased to be here. Thank you for invitation. Thanks to the organizers. Thanks to Andrea and thanks to Giorgio to invite me to this event. And well, it's a lobby evening for people with migraine, right? And yes, please consider me as their advocate and their lobbyist. And of course, each of us could talk about migraine for an hour, 2, 3, but I learned the time is limited, 10 minutes. So I brought several messages that I would like to share with you. First is, migraine is frequent. 18% of females and 8% of males all over the world have migraine. And, but there is also another look at it. Several years ago, we performed a European-wide study in 10 European countries and surveyed 8,000 respondents. And we asked them whether they had migraine yesterday, because everyone clearly recalls whether they had day before headache or migraine or not. And guess what? 17% of them had headache day before, 6% had migraine day before. If we extrapolate it, it means that every single day in Europe, 6% of European population have migraine. So migraine is frequent. But even more, 3 to 4% of the population, general population, have headache nearly every day. And 0.5% have so-called chronic migraine, which is a migraine almost every day. So that is the first message. The second very important message still is that migraine is not the psychological problem of hysterical ladies. Migraine is a neurobiological disorder, like stroke, like multiple sclerosis. And why do I point it out? Because people with migraine are still stigmatized. Nobody would call stroke a whatever. They take it seriously. But migraine, it's still sort of a girly disease, which is definitely not. The third message is that the migraine is much more than headache. Of course, headache is the most prominent symptom of migraine, but migraine attack starts almost a day before with mood changes, with sleep disturbance, with increased appetite or thirst, or diarrhea, even diarrhea, and 10% of a migraine patient will have an aura, like a visual aura, numbness of arm and leg, or even weakness or speech disturbances. And only after that they develop severe headache, pulsating headache with nausea, with vomiting, and all these will last like a day, 2 or 3. And then it's finished by fatigue, which lasts another 24 hours. So all this is a migraine attack, not only headache. Well, then we clearly understand that the quality of life during the migraine attack is reduced and destroyed. And we also understand that it clearly depends on the frequency, on its frequency. So if I have one migraine day per month and Giorgio has 20, it's a clear difference. And that's all about migraine, because migraine significantly reduces the quality of life. Migraine is not a killer. Migraine does not kill, and migraine does not lead to a permanent disability. But migraine is a frequent disabling disorder that reduces the quality of life, and not only of the individual, but also of the entire social environment. They suffer with them. So this is a message for. And in our Eurolight study, we also asked these people, especially those with many, many migraine attacks, like with chronic migraine, and they said that even during the interictal state, they are not 100% healthy, because they turned out to have comorbidities. They frequently suffer from depression. They frequently suffer from anxiety. They have fear about the next migraine attack. And if they are not adequately treated, they take painkillers every day that destroy liver and kidney. So this is a message 5. If we talk about burden, we also should mention definitely the so-called GBD study, burden of disease study. And this study is performed every 10 years by the Institute of Health Metrics Evaluation, based in Seattle and founded by Bill and Melinda Gates Foundation. And what the Institute does is they summarize all available studies all over the world to compare and to evaluate which disease is the priority in different regions of the world. So they compare the different diseases to each other, and they use the sort of mathematics behind, which they calculate the prevalence of disease, the chronicity of disease, and the severity of disease. And if they calculate it, migraine ranks in number 7 in all non-fatal diseases that we human beings have. And if we look at the population under 50, the migraine ranks place 3. So in the phase of our life, when we build our career, when we ground our families, we receive and raise children, migraine can be a real handicap for these people. And one would think that the disorder, which is so prevalent, so frequent, and we, all of us, doctors, like a GP, neurologist, pain specialist, emergency, we see a lot of headache patients because there are so many of them. And one would think that the society considers it as an important problem and treats it accordingly, but it's not. Unfortunately, it's not. In the Eurolight study, again, we studied the quality of medical care that the people receive. And it's terrible. The majority, 65% of patients, people with migraine, never contacted a doctor. And we talk now about Germany, about France, about Netherlands, about Italy, where people have a free access to medical care, though they don't have barriers, but they still, 65% of them, they never contacted a doctor. And if they contacted the doctor, the majority of them were underdiagnosed and undertreated. And it's really sad because this, it's not only about the quality of life, it's also about the loss of their work productivity. It's about presenteeism. People with migraine, well, of course they take a sick leave, but the majority of them, they go to the work because they don't want to make it public. But they are not productive because they have headache on the workplace. And it's very difficult to study these, but we were able to perform one study in Turkey in a Ford factory in a city called Izmit. And it's very interesting that we found out that 2.5% of employees with chronic headache were responsible for the loss of total product. 50% of a total loss of productivity was caused by these 2.5%. So now, if you were a manager of this factory, what would you do? You would enable this 2.5%, the access to the medical care, and you would increase the productivity by 50%. It's very effective, isn't it? But it's not done. And it's really sad because if migraine would be like an Alzheimer where we do not have any medication against it, but migraine can be effectively treated. We have a good medication for acute treatment. We have good medication for preventative treatment. And now we face even the more exciting times where several novel medications come to the market. And using them, we can reduce the frequency of migraine by half in every second patient. And this medication is well tolerated. So I personally think it's our duty, doctors, patients' organizations, policymakers, pharmaceutical industry, to enable the right medication to find the right way to the optimal patient. It's not enough to have good drugs and to put it on a shelf in a drugstore. That's not enough. It's clearly not enough. We have to take care of it. And in summary, there are several key messages. First, migraine is frequent and disabling. Migraine can be effectively treated, but it's not. And it's up to us to pave the way and to enable people with migraine adequate medical care. Thank you very much.
Good evening, everyone. Thank you for coming. As our MP said, unfortunately, there are lots of other important things happening around. So my name is Andreou. I'm the Director of Headache Research at the Headache Center. And I'd like to introduce our next speakers, who is Dr. Giorgio Lambrou, our lead consultant neurologist at the Headache Center, and Mr. Richard Key, who is one of our long-term migraine patients, who has an interesting story in terms of his journey towards the right treatment. You may think it's an extraordinary story, but actually we found out that is the common story that we hear from most patients. So I welcome both of them on the stage.
It's really great to see you, all of you here. We thought that because of the Brain Awareness Week, we thought that we needed to do something for migraine, given that it's one of the leading disabling neurological disorders. And we need more of these events. We need more exposure. We need to influence people to do more of this. This took a lot of energy from our point of view, but I think it's worthwhile. Because it sends a message out there, okay? So that's what we do as a headache center. We are a dedicated center to treat headache and facial pain disorders. We're not a clinic. We run 15 headache clinics a week we have the opportunity to use all the state-of-the-art treatments, and we want to make sure that people out there know what treatments are available and how to get them. So we want to inform them, we want to influence them. That's what we're here for. We want to train young specialists, we want to train old specialists that, consult a neurologist or pain specialists that want to have an expertise or an exposure into migraine. That's our mission as clinicians. We're not happy with how things are at the moment in the country, in Europe as well. That's why we dedicate 90% of our profession to the management of these conditions. So I thought having a chat with Richard would have been a great opportunity to talk about the challenges that many people with migraine face in their lives. And I think I'll ask you a few questions. Starting from how long have you been having migraine for?
Good evening, everybody. I have suffered with migraine for about 30 years now, all in total.
And did the pattern of the migraine change over time?
Pattern has changed quite significantly. In the early days, I suffered with about 4 or 5 migraine days per calendar month. And over the next 20, 25 years, that built up to in excess of 20 migraine days per month.
And so what kind of support did you get in primary care and in terms of referral to general neurology back in the days?
In those early days, I moved around a lot, house-wise, different parts of the country. Net result was that I was seeing many GPs and different general neurologists. I was given different medication each time, whether it be through the GP or whether it be through the neurologist. And sad to say that in almost all instances they didn't work.
So I think one interesting thing was I think you told me some times ago that you were diagnosed with classical migraine.
Classic migraine, 1995.
Classic migraine. What does that mean? It's interesting, right? Because classic migraine means, can you have non-classic migraine? Does it tell you anything about the disability or the severity of the migraine? So episodic tells you something, chronic tells you something, hemiplegic migraine tells you, but classical migraine doesn't, right? So going back to the definition, I think it's really important, and that's part of the problem. When you define migraine, you have to make sure that you define it also according to the disability. So saying that someone's got migraine, it means something, but it doesn't tell you the whole story. And then so you mentioned that most of the medication didn't work.
Yeah.
But then there were some that actually did work somehow, but then you had problems with them.
Yeah, over the time that I saw these different GPs and neurologists, I probably had between 13 and 14 different prescribed medications that were provided for me. There was one, atenolol, is that how you pronounce it? Atenolol?
Yeah.
Which worked quite well. But there were side effects. One of the side effects, and the significant one for me, was the fact that it took my pulse rate, blood pressure was reduced, pulse rate down to between 45 and 50, which made it very difficult to stand up straight.
Yeah. So what was your perception about the way that you were treated? Because from your history and going back and looking at the notes, I thought it was more like a trial and error exercise.
Absolutely.
There wasn't any sort of tailored treatment to your condition. But is that what you think as well?
Unequivocally, what I would say from the times that I saw the GPs and I saw the general neurologists, they themselves were limited in their understanding of what it was they were trying to treat. And through those medications, through the ability of the internet now, you can look at what you're actually taking, and it was quite evident that all the medications I was taking actually weren't designed for migraine in the first instance. It was just a byproduct in most people why they were actually being taken. And for some of the actual prescriptions that I was having, I couldn't get up in the mornings, and so the side effects just made it impossible for me to take, because as the professor said earlier, you've got to work.
And this is part of the problem. So if you look at the studies, after 6 months of people taking the preventive medication, especially pharmacological treatments, just a minority of them is able to tolerate them at 6 months because of the side effects. So even long-term treatment is very difficult with these tablets.
Absolutely.
And I think, how many neurologists did you see before coming to us?
I saw 4 different general neurologists before I actually got referred to yourselves.
And at that point, you were having very frequent migraines, what we classify now as chronic.
Absolutely,
yeah?
yes.
And what was the impact of them at that point? To your
I would say at that particular time, it defined my life. It meant that every day I didn't know whether I was going to be fit to do my job, whether I was actually going to be fit to do whatever was designed to be done at the given time with my family, and you had to look at contingencies in every instance. So it was very much it defined my life.
To the point that I think the impact was so bad that at some point you tried to look for a radical treatment.
I did. I took, some might argue, a rash decision, but there was an advert in one of the Sunday papers that migraine surgery was now available, and that it could, if not get rid of my migraines entirely, but a good chance of it being reduced quite significantly. So I went along to London to see a specialist there, had a consultation. It was deemed that I was suitable to have this operation. I had the 2 corrugator muscles taken out of my eyes, and I had I think it's right in this pronunciation, a resection of the semispinous muscle in my neck. Yeah. Which might come as a shock to some of you, but it actually worked for 7 months. I was actually almost migraine-free for that period of time. And then at the end of that pretty much 7-month period, the migraines didn't just evolve, it just went straight back to the 20 migraines or so per month.
And I think I mean, you probably have heard of this surgery, corrugator and occipital muscle decompression, which has got very mixed evidence and is currently not recommended anywhere in Europe, I would say. The main reason is because migraine is not a peripheral nerve disorder, it's not a muscle disorder. So if you decompress the trigeminal or the occipital nerve, you just give some transient relief, and that's all. But I mean, that's the kind of disability that the migraine was causing.
Absolutely. I would have tried anything.
And then you came to us, right?
Yeah.
And we started some different treatment from tablets. Yeah. And how have you been feeling more recently?
I've been under your guys now for a little over 4 years. We've had a series of different medications that have been tried, some of them prescribed, some of them actually over-the-counter options. And what I have seen during that time is a definite reduction in numbers. They have come down to anything between 8 and 12 a month. There were times when they actually went less than that, but they also had periods where they were slightly higher. We've had different medications that have been provided. And most recently, I've just undertaken a new medication, one of those that is actually designed for migraine sufferers. I'm now into the end of almost my month 2, and I wouldn't be exaggerating to say that at the moment the results have been pretty profound.
So why do you think, from your experience, why do you think people still believe that, still think that migraine is just a headache? Why do you think that's... it's a difficult question, but I mean, if you...
Use the analogy that if you've broken your leg, you know what that pain's like. If you haven't, then you have no idea. Okay?
Fair enough.
I would use the same analogy with migraine and headache. If you've had a headache, you think that all a migraine is a bad headache, and it most definitely isn't.
And if you had to suggest us something that we should improve in the future, in migraine in general, what do you think is missing? Well,
for me, I had 20-odd years of seeing GPs and general neurologists who, with all due respect, were limited in their understanding and knowledge of how to treat the condition that I have. I was very fortunate to be referred to Dr. Lambrew's team through a general neurologist. And the net result is that it's given me a vehicle to understand what I have better, to give me different options to consider, and to understand that they understand my predicament to a far greater extent than people that I have actually seen in the previous 25, 30 years.
Right. Thank you very much. I think
my pleasure.
Thank you very much for joining.
Our next speaker is Mrs. Elena Ruiz de la Torre. She's a world traveler. She actually struggled to get here, so it's a great pleasure to have her around. She is the chair of the European Migraine and Headache Alliance, and she's going to talk to us about the mission of the World Migraine and Headache Alliance. Thank you so much, Elena.
Thank you. Thanks to you. Thank you very much. I am very short, and by my accent you will see that I am Spanish. I'm not English, but I am very, very excited to be here in such an important day, such a historical day, and even more, I am very excited because we are at the Houses of the Parliament speaking about migraine. This is, I think, the first thing that happens, and it's really important. I know how difficult it is to get to here or to any other situation like this one, so I would like to thank you, the organizers, for having succeeded with this, and of course, for having invited the patients to speak today. Currently, I'm the Executive Director of the European Migraine and Headache Alliance and past President, and I am the Honorary President of the Spanish organization. I am working in this field for 15 years, and I think it's a lot to do still in our hands. So we really need all of you together to work and to move forward this situation. The European Migraine and Headache Alliance is an umbrella organization that includes 31 national member organizations that work in their countries, in their European countries. It was born 14 years ago in 2005 with the interest, and Wendy, who is around, was there seated at the table too, representing the affected people by migraine and other disabling headache disorders, to add value to the work that it's done at the national level, to give visibility to the disease, to voice the view and concerns of the patients, to defend the patient's interest, and to inform and influence policymakers on the real burden and to propose ways of improvement to the affected people, to improve their life. To work with other stakeholders with common goals to get to them, to fight them, and to fight for access to treatment, and especially to the most innovative treatment for everyone. That takes us to I have the page out there. I'm going to tell you about some examples of things that we are working at the European Migraine and Headache Alliance. Like, for instance, we are working at this moment in a communication campaign, social media communication campaign that will be run. It's led by Europe, but it will be run at global level. And what we want to do is to empower the patients, because we don't want. We know, and Richard, you will be recognized like this. You are a strong person. You are a resilient person. You are responsible. You are born like anyone else, and you carry on your life plus your migraine, and nobody knows it, because you have been hidden and you have been trying to fight and to hide it and to move forward and to live. Even more women that have their housewives, their children, their works, their jobs, everything. So we are trying to organize now a social media campaign in which we empower the patients to say, and to the others to know how important, how strong, and how resilient the affected people with migraine are. And we also provide evidence with surveys, like we have one survey at Migraine at Work. It's called Migraine at Work. We gathered 4,000 answers from workers with migraine, and we asked them how do they feel in their workplace, how do they think they are considered by their colleagues, by their employers, by their environment, whether they have asked for any improvement or their workplace. How are they in their workplace? And we have gathered so many answers, so interesting ones, and now with those answers, we go to the policymakers, we start new projects, and we try to improve the life at the workplace. We go like twice a year to the European Parliament to talk to the MEPs and to try to change things. We also try to help science to spread their projects. For instance, we have now one around the pharmacist, in which we try to inform the patients that overuse medication is going to lead them to a chronification, and they don't have to overuse. They need to go to a real special neurologist and to be well cared. This is a serious condition. We also support the national organizations by going there to each of the countries and creating public days and events and activities there. And we represent the patients at the congresses with like European IHS, European Headache Federation, which Professor Sasa Katsarava said, or European Academy of Neurology, or all the scientific groups. Why did we decide to open the European organization and to create the global one? Migraine disease, as you said, Professor Sasa Katsarava, it's a global epidemic that affects around 1 in 7 people around the world. For those with severe and chronic forms, this disease is devastating and debilitating to the family, to themselves, to their quality of life. Migraine is underdiagnosed, undertreated, and poorly managed. Much of the burden, social and economic costs, could be preventable, but it's not being done. People living with migraine are heavily stigmatized and discriminated against. These disorders are deprioritized and underfunded too. An investment in research is the lowest one, and zero interest from the governments. We need to pay attention to that. We need to make a call to action and try to get some funds for research. And that took us to the World Headache Migraine Alliance. This status quo is not acceptable. History shows that in diseases where there have been a fundamental change in the society perception, respect, and treatment of the condition, the shift occurred when patients took charge of the demand and demanded for changes. And it is only the patients who need to demand those changes. Other diseases, other conditions are not going to demand or to call for our changes. We need to be active. We need to be mobilized. We need to be together, and we need to come out and explain what happens and how undertreated we are, how mistreated we are, and how uninformed or badly informed the society is about what happens to us. A global alliance of migraine and headache patients, advocates, and organizations will unite and empower our community by convening, sharing the best practice, and working together. We will improve the lives of 1 billion people living with migraine around the world. We will exchange best practices, and we will create activities to work as a unique voice in the whole world. We are already working with Australia, with Latin America, with US, of course, and with many countries. We will be launching this at the International Headache Society in Dublin next September, and we have already 55 patient organizations accepted with the invitation. And I want to finish by telling you 2 examples of what happened in my life. I want to tell you my first experience very short, because I know that my clock is already passing, and my last experience last week. 15 years ago, I went to a hotel, a very important hotel, Intercontinental Hotel in Madrid, and I was friend of the director, and I said to her, could you please help me one room for a public day in Madrid? I have just created a Spanish patient organization, and I need a room. I want to make the science come. I'm going to invite important professors here. I want to explain to the society why that happens in our brain, what's going on in our brain, why do we have this headache. And guess what she said to me? She said to me, oh no, Elena, I can't. If you are the cancer patient organization, I will put you a red carpet. But being migraine, who am I going to sell that to? This is impossible. So they didn't give it to me. That was 15 years ago, and that was one of the reasons why I decided to be so committed to this cause. But last week, I was at the European Parliament, and I was seated in a round table, and one MEP came and seated there, and then I said, well, thank you very much for being here in this event for us. And she said to me, well, I'm going to leave in 5 minutes. This is not an important topic. And I said, why do you think this is not an important topic? And he said, well, there are other diseases which are much more important than this one, like cancer or Alzheimer or Parkinson. And then I said, what's the reason why you think it's not important? Because we don't die because of that? And she said, yeah, that's one of the reasons. Everyone has a migraine or a headache. And I said, if I tell you that I have spent already 7 years of my life in bed, dead, without being able to do anything, will you consider it as normal, as what you say, just a headache or whatever, thing like this? And she just stared at me and said, well, we'll have to think about this. Maybe if it's like this, but this is special. So they don't really know. They don't really understand. They don't know anything, and we really need to be mobilized. We are invisible, and whatever you don't see doesn't exist. We need to make ourselves visible. We need to expose ourselves to the society in general and tell them that this is real, a neurological condition, that it conditions all our life. And this is something that I always, this question, it always comes to my mind. Why, if this is a disorder or a condition that has conditioned our life in such a way, so much, why the others don't care about it? Why nobody cares about it? Why the others, they are like, well, they don't mind. Thank you very much for listening to me, and please, let's be together, work together, fight together, and have one strong voice around migraine.
So our next speaker before the break is Wendy Thomas. I know Wendy for many years. She's the immediate past CEO of the Migraine Trust. She can tell you more about it herself. And the topic that Wendy wanted to discuss here tonight is about migraine at the workplace. You heard before how disabling migraine can be and how much people are affected at the workplace. Thank you, Wendy.
Hello. Thank you very much to Anna and Giorgio for inviting me. It's very kind. And it's very important to have these meetings. I do totally agree with that. I'm here being a bit fraudulent because as from last week, I'm no longer the Chief Executive of the Migraine Trust. Gus, who will put his hand up now, is the new Chief Executive who took over last week. But it's only day 8. We thought perhaps, you know, he might let me do it. So we're in the process of a handover, and then I'll be retiring again. So really, the idea was to just concentrate briefly on migraine in the workplace. A large proportion, I mean, the Migraine Trust, just quickly to say, I'm sure most of you do know about us. We thought we were going to have some screens with some information on, but we were formed in 1965, originally as a research charity, and then that gradually morphed into providing evidence-based information. And we have Susan, who is over there, but she's sitting down, but she will be around in the break to talk, who's our information manager, and Una, her comms manager, is over there, and she's busy tweeting. So you can ask them those sort of things. But we're basically patient-focused, research-driven charity that works with providing information and help to patients, as well as funding research. And we have research, our PhD research, Joseph here. Anna's one of our fellows. Piari is here somewhere, who's Piari, who was our research fellow, who finished about a year ago. So we do both things. But in terms of migraine at work, a lot of people, a large proportion of the people who contact the Migraine Trust, we have an advocacy officer who works with people and helps them with employment issues as well as education issues, and also getting referred to the right person. As a lot of people look for support with workplace issues. Most of them have the problems that have been mentioned earlier, so I don't particularly want to go in those. It's usually about employers who think it is just a headache, who don't understand, and think. And of course, quite often, you know, people don't say they have migraine. They don't say it when they go for an interview, and who can blame them? There's a lot of stigma, and they're afraid no one's going to employ them if they are going to have problems. And there are difficulties. In my experience of many people, including in my family who have migraine, you know, people would rather go to work and go and throw up in the loo than admit that they've got a migraine. You know, presenteeism is quite often quite rife. And so it's really important that an employer can and will understand. And we want employers to understand that they have responsibilities for the health and safety of their employees. So we've talked about mindful of migraine in the workplace. So we want employers to be aware of that there are high numbers of people with migraine. It's very common. Have an understanding that it's a complex neurological condition and make reasonable adjustments. And I think one of the biggest problems has always been sick leave, so that you can trigger a sick leave problem if you've had so many days. And of course, if you go off and you look okay and you come back 2 days later or 3 days later and you look okay, nobody really understands what's going on. And after you reach a certain point, you might trigger a meeting with HR, who then start to put more and more pressure on people, which makes it more and more difficult for them, in fact, to continue and probably exacerbates their whole conditions. Workplaces can help. There's a person called Sammy Ashby, we've been talking to quite a lot, Deputy Chief Executive of an epilepsy charity. She's able to have well-being sessions with a colleague. And that a lot of employers are doing this with mental health now, well-being sessions, trying to find out what works for people, what helps them, having regular reviews. Those are all very, very important and help to come up with solutions. And that will benefit organisations. The Work Foundation revealed the scale of the migraine on the economy last year. I'm not going to give you the actual figures because I think I haven't looked at them closely enough in the last day or so. But there's millions of work days lost every year, and this is costing the UK economy almost 8 billion a year. And that will be absenteeism, presenteeism, those sorts of things. So we really want to be able to help those people. We do have a toolkit for employers and employees to help people with migraine in order to help their managers, trade unions, HR departments, occupational health, about ways to manage it. And as those of you who suffer from migraine know, it's not just a workplace issue. It's a life issue about whether you can make it to, the parents' evening at school or somebody's wedding, all those sorts of things. And I think the other thing that we really need to concentrate on is getting at the employers themselves. We have found over the years at the Migraine Trust that big employers are not very interested, actually. Many years ago, at Migraine Trust International Symposium in 2006, we tried to give an award to the best migraine employer. And we asked people in the workforce to nominate them. And it took us, so we got some nominations, and we went to go number 3 before the person would, and that was British Gas, or was it British Telecom? It's a long time ago. Anyway, one of them said yes, and the other 2 didn't want it. They didn't want people to think that they were soft touch for migraine. Difficult to get into employers. Difficult. Amazon, look at Amazon. Do you think they'll allow people time off for work? Do you think Barclays are good? Do you think banks generally are good? But we can't, but we find it very difficult to get into big employers. Now, what Elena's just said, which is interesting, because I'm also the International Headache Society's treasurer for my sins, and that is supporting the Global Patient Advisory Coalition is actually part of the IHS. And they are looking at working with employers and thinking that they can talk to big employers in the UK. Now, that could be a significant step forward. So we watch that with interest. Thank you very much.
So I think it's about time we start. However, before we do so, we would love to thank Jim for hosting us tonight. As you all know, it has been a very busy week or busy months, and it's actually a privilege to be here tonight with Jim as our host. So thank you very much. And this is
Thank
for
you.
the- Thank you.
Okay.
let's open the second half. We are going to hear from Victoria Polito, who is a pathway lead NHS Right Care at NHS England. Victoria is going to talk to us about the development of a headache and migraine toolkit. We're very privileged to have you here. Thank you very much. Please come through.
Hi, so I'm Victoria Polito and I lead the Pathways programme in NHS Right Care. NHS Right Care is a nationally led programme, but we deliver it locally through a team of what are called delivery partners at a regional level. Our programme takes evidence-based data to identify opportunities for improvement to improve population health, improve quality of care, and we are very much around addressing unwarranted variation. So we are a clinically led programme. We have a clinical advisory group that is led by C. Liveringham Clark, who's the medical director in NHS England. We have Simon Mackenzie from NHS Improvement and Professor Nick Harding, and they sit as our clinical leads and support the work that we undertake. We employ a methodology in NHS Right Care called Diagnose, Develop and Deliver, which is we're trying to diagnose what the problem is, we try to develop solutions, and then we use our delivery partners to deliver the solutions and work at a local level. The area that I work in is called, it used to be called Pathways, we've changed it to Toolkits because we're trying to provide expert frameworks to support local areas to look at service transformation at local areas. So we predominantly work with CCGs and commissioners, although with the changing landscape, we're also now working at ICS level and STP level. And we're really trying to support commissioners to look at how they commission services to support people to improve their outcomes. When we develop the toolkits, we work with a range of partners. So we predominantly work with NICE, Royal Colleges, the national clinical directors in NHS England, leading clinicians and experts in the field. And what the toolkits are trying to do is try to identify what that high-level overarching case for change is, to really put a topic on the map, as it were, to get commissioners to have a look at it. And neurology has often been overlooked by commissioners at a local level. So we're trying to shine a light to actually get commissioners to have a look at what the issues are on their local level. The toolkits try to identify what the key high-level interventions and priorities are, so we try to provide everything in one place to support commissioners. They don't have to go off and look and find what the evidence base is, what the high-level interventions are, because we bring all of that together by working with our stakeholder group. So we're in the process of developing a headache and migraine toolkit. We know it's an important issue because approximately 10 people in the UK live with migraine. We know that it's one of the most common neurological reasons for A&E attendance, and that is putting a huge pressure on A&E services. We know that approximately 20% of patients have a chronic headache due to medication overuse, and we know that up to 1/3 of new specialist neurology appointments is due to headache and migraine. Now, in the challenging situations that we're in currently in the NHS, we need to try to reduce that burden and free up neurology time for the most chronic of patients. And if we can support GPs to help manage patients in primary care, that's what this framework is aiming to achieve. So in developing this framework, we have worked with the Migraine Trust, we have worked with BASH, we have worked with Public Health England, the Walton Centre and various different CCGs to come up with the framework. And the key messages are that we need to support GPs in the correct identification and management of headache and migraine so that patients are referred into secondary care when it's appropriate, but they are also managed in primary care when it's not. But GPs don't get a lot of education around headache and migraine. They get a very small section in their training, and often this isn't revisited. So we need to support GPs into the identification and management of headache and migraine. As I mentioned, we're trying to reduce inappropriate referrals into secondary care because there is a great pressure on secondary care at the moment. If you're taking up clinic time with patients that don't need to be there, you're increasing waits for those patients that may have a further chronic condition that needs to be seen. We are also trying to support patients to self-manage their own condition as well. And we were talking earlier about getting employers to understand we need to work with patients so they have a voice, actually, so that they can talk to their employers about their condition. And we're very much advocating throughout this toolkit that there needs to be an element of shared decision-making and personalised care with patients. So patients are empowered to speak up and to work with their with their providers and their clinicians, so that they can actually say what they want from their treatment. It's not done to them, it's done with them. We want to support patients in the use of undertaking headache diaries to understand their own personal trigger points, so that when they do need to speak to their employers, they can do. They've got a record, they understand what their triggers are, and it will help support them in the workplace. We also want to focus on supporting pharmacists as well to help support our patients, because again, GP time is very stretched, it's very limited, so we want to empower pharmacists to help support patients in the community. But equally, we need to understand around the long-term management of patients in primary care or in community care. So we want to support clinical commissioners to develop community headache and migraine clinics, to actually invest time in supporting GPs to become GPs with special interests, so that they can also support patients. And so if patients do need to be seen, not in the secondary care environment, they can actually be seen in the community, which we know through research with patients that actually being seen in care closer to home can actually improve your outcomes over the long term. We are also working with another programme within NHS England called the Elective Care Transformation Programme, who are undertaking what's called a Wave 5 neurology programme, and they are testing various pilot sites across the country. I think there's 6 of them who are looking at different interventions for headache and migraine, and actually again it's about freeing up neurology time in secondary care. So they're looking at different pilot things, trialling, for example, when a referral is made to secondary care using a colour-coded referral scheme. One area is looking at a triage system, and we've got pre-referral forms for triage. We've got one CCG that's looking at education sessions across the whole CCG, that's that all of the GPs in that CCG have education sessions across the board. So we're waiting for the results from the pilot schemes, and those pilot schemes will link into the work that we're doing and will link into the framework that we're producing. We are aiming for the framework to be produced over the next couple of months, to be published over the next couple of months. We have a framework already, but as some of you are probably aware, we're going through a bit of an alignment with NHS England and NHS Improvement, which has slowed some of our publications down. But we are committed to this agenda, and we want to get it published as soon as possible, because the earlier that we can get this out into the system, the earlier that we're going to make a difference for patients. Thank you.
So, our next speaker is a GP with a special interest in headache. He's one of these doctors that we really want around the country, Dr. Richard Wood, and I quite like the title, and headache in primary care, a commissioner nightmare or a commissioner dream. I hope you have a couple of minutes also at the end to tell us how it's possible to diagnose migraine and treat migraine properly in 10 minutes in your clinic, but only if you have time. Thank you very much. Please.
Thanks, everyone. Thank you very much indeed. And Anna and Georgia have done a really great job tonight. It really is fantastic. So, I'm a GP. I'm a GP with a special interest in headache. I'm a neurology lead at the Oxfordshire Clinical Commissioning Group, so I'm a commissioner, and I also do some medical politics as well. That's my potential conflict of interest, don't know. So I'm going to wear 2 hats tonight. The first part, the first hat, if you like, is about GP struggles in correctly diagnosing migraine and treating it, and that's been coming up tonight, and I'm really glad it has been. And the second part, I'll talk about the system struggles as a commissioner in headache in particular. So, GP hat. Teaching on headache is very limited. I remember 1 hour of teaching on headache through my entire clinical medicine training as a medical student. That is awful. Now, this has 2 importance equally for all clinicians actually coming through. The first one is that there is an underdiagnosis of primary headache disorders, such as migraine. So, for example, we know that if a patient presents to their GP with headache, they will get the diagnosis of migraine 17% of the time. Now, when the GP makes that diagnosis, actually, they're almost always correct. So when we think it's there, it is there. The problem is, what about all those other headaches they're not diagnosing as migraine? In fact, what we know is that almost all of them are also migraine or migrainous. In fact, 94% of all headache presentations for GP are actually migraine or migrainous. So the message, I think, certainly in primary care is when we're training GPs, but for all generalists out there really, is that when a patient presents with a stable pattern of episodic, disabling headache, but has a normal neurological examination, we should assume that is migraine until proven otherwise, and that way we will treat an awful lot more migraines effectively from the outset. The second importance equally of limited teaching in headache is that there is an overdiagnosis of serious headaches. So if you only have 1 hour to teach on headache, what are you going to teach on? You're going to teach on the nice red flags of headache, those features that where present suggest there might be a serious underlying neurological condition. But the problem is that there's therefore an association in the learner's mind between headache and danger and risk, harm to the patient, and indeed litigation. And the result of this is that benign features of migraine are misinterpreted. I've audited my community headache clinic, the reasons for referrals, and for one of the main reasons, for example, is the referrer is saying this headache is onset at night or worse in the morning. Now, what the referrer is thinking in their mind is they've got that nice red flag of orthostatic headache. That is a headache which is worse than lying down. It must be raised intracranial pressure. But we know that actually that's much more typical of medication overuse headache or indeed migraine, and those are much more common than raised pressure in the head. Sorry. So there is this misinterpretation, if you like. I think the solution, one of the many solutions, of course, is to increase teaching, but we need to be focusing on what I call the green flags of headache. What features are there which should reassure the assessing clinician that everything's okay? And there are lots, actually. Episodic, it's stereotypical, you can see, you know how it's going to pan out, that sort of thing. There are many. So, let me put on my commissioner's hat. This risk aversion I've been talking about, which we really need to bring down, what's the result? The result is 1 in 3 referrals to neurology are for headache. Most of those referrals are asked to be seen urgently because the referrer is worried. We also know that most of those referrals end up being migraine. Now that's a problem because migraine should be diagnosed in the community and treated in the community where it's easier to access to the patient and it's much cheaper for the health economy. This is the commissioner's nightmare. So a single outpatient appointment in the neurology outpatients department is £240. That's for a half an hour assessment. Compare that to £125 for a whole year of unlimited access to GP care per patient in Oxfordshire. It's very expensive in the hospital. So we developed the Oxfordshire Headache Pathway to try and grapple with this problem of a big deluge of headache referrals going to neurology inappropriately where they could be supported in the community. So what we did is we picked our best clinician, our headache expert, a headache consultant who triages all headache referrals coming through, reads them all, and rather than just sending everyone to the outpatient department, they've got other options. So they could dictate a letter back to the GP saying, don't worry, this is migraine, here are the guidelines, we're here if you need us. Or they might send the patient directly to a scan, and if the scan's normal, everything's okay, much less wait time, patient's happy, GP's happy. Or indeed, which happens with most of them, the referral might be sent to a community headache clinic seen by a GP with a special interest in headaches, such as myself. There's 2 of us out there in Oxford at the moment. Now, we're just piloting this at the moment, but at full rollout, what we anticipate on the data so far is an 89% reduction in the number of headaches seen in the neurology outpatient department. And that's 980 freed up appointments for other neurological conditions. That's very impressive. And those alternative options I've mentioned, they're quicker for the patients are happier, and they're much cheaper. In fact, we anticipate that the cost of headache in the neurology outpatient department would have been reduced by 65%. That's the Commissioner's dream. And the key learning points I want to share with anyone here who's thinking about developing such a pathway is that you have to have your best person triaging the headache referrals. You have to have your expert doing it. And this is an observation. The NHS referral system is not built for this sort of pathway. It is not fit for purpose. With the electronic referral system, the ERS by which all referrals come in, the referrer, the GP, chooses the clinic the patient should be seen in. The GP chooses the time frame for that. As we know, referrers, not just GPs, but there are other referrers out there, we get it wrong sometimes because we're generalists, but we get it wrong a lot. In fact, the triager, our expert consultant, can't even read the letter until the patient is booked into the clinic. So then if there's going to be changes afterwards, it leads to confusion and disgruntlement. It's just not fit for purpose in its current state. Right, I'm going to finish off very, very soon. I was asked to make some comments about why treatments and technologies in headache are perhaps slow to be taken up by local commissioners. And I'm going to list you 4 reasons out of many. The first one, and this is the most important one, is that the outpatients department is not coded. By that I mean the outpatients department is not counting the number of different diagnoses coming through. We have no idea actually how many headaches are coming through, or Parkinson's disease, or whatever. We're just not counting it. That's a massive problem for commissioning, because if you have a new treatment coming down, the commissioner needs to know how many of my patients in this patch are going to be eligible for that treatment. And once you know that, then you can do your financial modelling and your financial planning and see how it fits in. But without that local data, you just can't. If I had to change one thing, I change that. Second problem, third parties, perhaps drug companies, for example, are very helpful in trying to build business cases for commissioners. And I don't want to dismiss that. That is actually very helpful. And they might say, here's a new treatment coming through, this is how much it's going to cost, and we reckon it's going to save you this and have all these benefits, etc., etc. The problem is they don't have that local data either, so it's data which is not applicable to our region. And there is perhaps sometimes a tendency to overinflate the benefits and not talk about the risks. But what the commissioner needs to know, and if you're writing a business case yourself, what the commissioner needs to know is not only what's the happiest outcome, but actually what's the worst case scenario. If all these assumptions are wrong, what's the maximum we stand to lose? They also need to know the most likely. And then once you've got all those 3 clearly accounted for in your business case, then the commissioner can make a reasoned decision. Thirdly, new technologies and new treatments need front-loading of money. And the savings of that, if they're there, are only realised downstream, perhaps in the next financial year or beyond. But there is so much pressure on commissioners now that we have to make in-year savings. So something which says, it'll save you money over 3 years, that's very difficult for a commissioner to justify. And finally, I'll leave with this question: whose budget are we saving? So if a new treatment comes in and it says, this is going to reduce absenteeism and presenteeism for migraine sufferers, that's fantastic. That's fantastic for the patient, that's fantastic for society, and that's fantastic for the economy. Those treatments need to come in. But the problem is that saving to the economy doesn't get passed to the commissioner. The commissioner only is burdened with the financial risk. That's a perverse incentive. Thank you very much for listening.
So it's an honor for me to introduce the next speaker, Professor Adrian Williams. professor in neurology at the University of Birmingham, chair of the National Neuroscience Clinical Reference Group, and it's a pleasure to have you here tonight. He's going to talk to us about developing what good looks like for headache. Professor, thank you very much.
Good. Anna Giorgio, thank you for inviting me, and having met you, I would still have come. And there's a serious point there behind my comment that if people like me can't encourage young consultants who are trying to set up services to realise that although Stalinistic that NHS England sometimes look like, that they can actually make progress. In my generation, neurologists could be quite entrepreneurial, quite initiative, and I think just by pulling this meeting together, you've shown that, and I think that's my serious point, really. Because if we can keep that going, to be honest, I think everything else will sort themselves out one day, including, you know, when we got Richard talking sense on commissioning and on GP land. So thank you for inviting me, because I'm now pretty optimistic about this. Can I give you a bit of background to what I get up to? So the CRG is part of NHS England. It's SpecCom, so it's specialist commissioning. So kind of indirectly we pay for some headache services, but probably at the top end, the red flag end. You know, so subarachnoid hemorrhage is a big thing for us. Thrombectomy, very much the point that Richard made, that you do thrombectomy, but who actually saves the money down the line when it's actually, rehabilitation or, because you got a patient better, but the commissioner can't see that, and so you have to do a deal. So exactly that point is really important. So this business about dealing with SpecCom and then dealing with whole patient pathways is a massive issue. So the CRG, in theory, just deals with specialist commissioning. So we do talk about headaches sometimes, but not very often, and as I say, really at the dangerous end, which is clearly rare, but obviously important. So we've got a second structure called NNAG that Hannah helps administer now. NNAG was an agreement between the Neurological Alliance and the ABN and the SBNS, and it's unusual and it's specific for neurology. And in theory, at least, we're allowed to look at the whole pathway and the whole of neurology, and we're not bound in a kind of process way to just deal with what the CRG is supposed to deal with. Having said that, the CRG has been allowed a service review. We had to go through several hoops, and we had to specify what we'd look at. So what we agreed in the end was that we would look at 3 pathways for neurology and 3 for neurosurgery. So we had to pick things that we knew that would interest them because they were spending a lot of money on it. So MS was an obvious one, and autoimmune disease other than MS because there's so much progress in that area, and epilepsy. So epilepsy is the closest analogy with headache. So why was that picked? Because it doesn't, it may have expensive drugs, but they're all CCG funded. There's epilepsy surgery, which we fund. It was partly because there's worries about excess mortality. So sometimes something like that will help drive something. And the employment issues that were brought up earlier may be the thing that helps you drive migraine. So I was very interested in that aspect of what you said. So the 3 work streams, the 3 for neurosurgery, actually they do include the top end. So oncology, subarachnoid hemorrhage is a big thing there, and we deal with it. We work closely with stroke over thrombectomy. So that's kind of what we'll get up to. So what am I going on about that might be helpful? So on the 3 work streams that we are looking at as non-normal CRG business, the first thing we've asked them to do, and they can use GIRF, they can use right care, but we're still asking for some clinical vision, is to essentially give us what does good look like for MS, what does good look like for autoimmune disease, what does good look like for epilepsy, And I start off by saying, I think you can get it on one slide, one diagrammatic slide, with a second page of justification. Now, I'm not saying they've quite got there, but they're close. And what I'd be very interested in, and I appreciate you've probably done this already, but I think I can help take it through a kind of national structure and say, look, not so much probably through the CRG, because they will say you weren't allowed to look at that, but we can do it through NNAG. If we could say, this is really what the experts, backed up by a reasonable amount of data, say what good looks like by region in the end, because regions are quite different. The Walton's different from Birmingham, Queen Square's different from everywhere. So, but nevertheless, the patient should be able to see quality, and it shouldn't actually matter what's under the bonnet, if you like, some of the time. You know, who employs the neurologist should be fairly irrelevant. If we could actually see that, and you may tell me either now and tell me off, or tell me at supper that you've already got it, I would say, fine, you know, there's not much work to be done, but can we see it? Or can you present at NNAG? And there's, you know, as I was talking to other people, keep it simple. If it's controversial, nobody else probably cares, you know. Just keep it simple. A patient, you know, and, you know, you can reference a patient who doesn't even go to their GP. You know, what's the advice that goes there? How, you know, you've probably done it all, but it'd be nice to kind of see it. So I guess that's my point. So thank you.
Thank you, Professor. So we're heading to the end of our lovely meeting, and it's a pleasure for me to introduce the organizer, we'll say, almost, who put a lot of effort into this, Dr. Andreou, who is our Director of Headache Research at St. Thomas's and at King's College London. She's going to give us some challenges in research in migraine, and hopefully also a bright side of it at the end. Thank you, Anna.
Thank you, Giorgio. And can I just say thank you to all the previous speakers, because I learned so much tonight, things I didn't know, and now I understand a bit better the system. And I will I will welcome the invitation to take actions in terms of things we have to do to make migraine and headaches a priority for the NHS. So thank you very much. We decided to host this event tonight during the Brain Awareness Week, which aims to increase awareness on the progress and the benefits that brain research gives for neurological disorders. And the brain is an important organ. It's important for all the senses, for the emotions, for actions, and when the brain is sick and breaks down, we break down. And surely that's how I feel every time I have a migraine. I'm a migraine patient myself. And I first got involved in this field after the disappointment I felt from attending a lecture at Queen Square during the first year of my training. And I heard Professor Kaube saying there that we don't know what is causing migraine. So I was very disappointed, and I thought I need to find out what is causing migraine. Well, 15 years later, yes, time flies, I'm happy to report that we know a bit more about migraine these days. We don't know what is causing migraine, but we understand a bit better the biology. We now understand that migraine is a state of the brain disorder, which accounts for all the symptoms that migraine patients feel, not just during the headache phase, not just during the head pain phase, but it also accounts for the symptoms before, the premonitory symptoms, and the symptoms after the actual headache phase. And actually, the problem is that during a migraine attack, the patients suffer, but in between they appear normal. And I think that's part of the problem in increasing awareness on migraine, that in between, when the patients go back to their work, they appear normal, so there is nothing wrong with them, right? In some patients, however, these symptoms can become more frequent. And in a way, in what we call the chronic migraine patients, they are so frequent that they get barely any headache-free day. So in their case, migraine can be even more disabled. Advances in understanding the biology of migraine have recently led to the development of more migraine-specific treatments. So our patients are in a better place than what they were years ago when I first started my training. Whoever thought that Botox can be a treatment for migraine? Whoever thought that using a magnet on the back of your head will actually help you treat your migraine? And actually nowadays we even have newer advances with what we call CGRP antibodies that target this substance called CGRP or its receptor. And they have been shown in clinical trials, and we now try to have them available in clinics to improve the headache and the frequency of the headaches in these patients. Very recently, I was giving an interview to a journalist about these new treatments, and the journalist asked me, so now that you have the cure in the migraine field, what your research will be about? So I got very disappointed, because yes, we do have new treatments in the field, but I'm afraid, and it's sad to report that we still don't have the cure for migraine. And we cannot find the cure for migraine unless we understand what is causing migraine. Of course, there are other reasons we should have headache research available and migraine research in academic setups. Part of the reason there is so much lacking of care for our patients is because doctors are not well educated to treat migraine patients. And why they're not well educated? Well, because they haven't been educated about headaches, right? They haven't been educated because there haven't been any teachers. And the reason there are no teachers around is because there is not enough funding to support academic researchers who will be willing to go around and teach into the medical schools about migraine. Myself and my team, we go around 4 different medical schools, and we provide teaching to the medical schools, to the future doctors on headache disorders. We are only allowed in most places 1 hour. However, this is better than what it used to be. We did a survey a few years ago, and out of the 34 medical schools in UK, only 5 had headaches in their curriculum vitae. So imagine the number of doctors that go out there without any knowledge on how to treat the most common disorders that they will see in their clinics. So we need more funding to keep these headache specialists, headache teachers in academia to be able to teach our future doctors. And we have the Migraine Trust here with us tonight. They have a huge burden on their shoulders. Unfortunately, the research councils have not been interested in funding headache research. You see, it doesn't kill people. It's not that obvious what the disability about the disorder is. So there is lack of awareness even within the research councils. So unfortunately, there is barely any funding from research councils. But you see, the burden that charities like the Migraine Trust have is not just about funding a new PhD student or a new fellow. It's also about supporting the people they funded already to remain in this field. And that's, I think, a bigger challenge for them. Because otherwise, they wasted their investment. The patients who contributed by donation to fund headache research and migraine research to the Migraine Trust, they are just wasted their money if researchers like myself, Joe Piari, and many others that have been supported by the Migraine Trust are forced to leave the field because of lack of funding. I think that will be a lost opportunity for our field. Tonight, we're extremely grateful to our sponsors. We have Allergan, Inura, Novartis. I only name them alphabetically, so they all, we thank them equally for their support. But we need a bit more support from them. We need their industrial support into basic research. And I can see some heads nodding, so thank you so much. You have to remember that UK used to be a very strong research setup years ago. This is where 5 out of the 6 triptans were developed. And it was done by industrial support and academic contribution. So if we don't have industrial support, especially with the lack of funding from research councils, I'm afraid this field cannot be bright. But we have to make it bright. We have to make it bright for our patients, so we need the industrial support. And we need to coordinate what is called these days translational research. So this is a buzzword. Everywhere you apply for grants, oh, it has to be translational. Of course it's translational. It's basic science on understanding the mechanisms of migraine, so we can then go back to the clinic and explain to patients, first of all, what is causing their disease, and also try to find out what treatments will be good for them and how we can advance the already established treatments, because maybe that's another approach. We can make the already established treatments even better if we understand how they work. But in order to do this, we need more funding in research. And we need to involve everyone in this effort. So it has to be the primary and the secondary care. We need all healthcare providers and professionals to be involved. We need the patients to contribute in having an even better research and teaching opportunities for our patients and for our bright future for migraine patients. So the principle for improving health, not just in migraine, but in all diseases, must be rooted in research. And headache research can only make a bright future for migraine patients. And I can reassure you that at the Headache Center, we are very committed in cutting-edge research, and I hope we can invite you back here, not in 15 years, maybe sooner, just to discuss what the cure for migraine is. Thank you very much. Thank you.
Wendy Thomas, Migraine Trust. I'm delighted to be here to speak at this meeting tonight. It's so important to have migraine on the agenda in the Houses of Parliament. It's a lovely, large group of people here talking about how important it is for migraine, how important it is to understand what migraine is, and how people who are in the workplace, in particular, I'll be talking about how to make it better for people in their workplace who have migraine.
Okay. My name is Elena Ruiz de la Torre, and I am the current Executive Director of the European Migraine and Headache Alliance. About the World Migraine and Headache Alliance, or how it's going to be called WHAM, World Headache and Migraine Alliance, it's going to be an umbrella organization that will gather all the patient organizations around the world. What we want is to have the same messages, the same wording, same ideas, the same goals, to share best practices among all the patient organizations and put them together and work with a unique voice and very strong one. This is what we are trying to create, and it will be launched in September during the International Headache Society Congress in Dublin.
So what do we mean by right care at the right place for migraine sufferers? We want to put patients at the heart of their care to be empowered to support themselves along with their local GP in getting the best treatment that they can for headache and migraine. We want to work with our local commissioners to redesign services to bring care closer to home for patients that suffer from headache and migraine. And that's what right care means to us for our migraine patients.
So the last point I was trying to make was about silo thinking in healthcare, that if you're set a set budget, and if the savings are realised somewhere else, if those savings aren't passed on, there's no incentive to invest in that. And we have to somehow have a structure which breaks down these silos, and the savings can be shared throughout the system. Now, there are new systems coming up, new ideas about how we can recreate a new healthcare system which doesn't have this silo thinking. They're called integrated care systems, if you like. And this is the future. Exactly how that's delivered, what it looks like, will it really get round silo thinking of budgets? We're yet to see, but at least we're beginning to realise for the first time that, that this is a problem, and we need to move in that direction. Thank you.
So I think I'm being asked if NHS England will make migraine a priority. Well, my answer to that is that it depends which bit of NHS England you're talking about. In specialist commissioning, it is possible that because it's such a common condition that it is not one of our priority areas, but we've got other structures within NHS England that takes headache extremely seriously already. And as in my talk earlier on, I alluded to getting a what does good look like for headache, because we think a lot of patients can manage themselves better, the GPs can manage a lot of patients, and less patients need to come into secondary care. But when they do come into secondary care, they need to see a neurologist with an interest in headache, or somebody who, in a sense, his only interest is headache, and gets involved with new clinical trials and new therapies. So I would argue that we do take headache seriously.